Good morning to you all. I am Dr. Vivek and working as Assistant Professor at Sri Gokulam Medical College and Research Foundation, Trivandrum. And I would like to cover the topic on how to approach a case of microbial keratitis with emphasis on the following topics. I would be dealing mainly with history taking and examination of a case of microbial keratitis. So rushing through the brief epidemiology, you have bacterial, fungal and protozoal keratitis. The common bacterial species which are involved, as you all know, staph, streptococcus, pseudomonas, uncommon ones being nocardia, neisseria, corynebacterium and moraxella. Then you have atypical mycobacteria. The common fungi, I am just rushing through all these because we have to cover the topic on history taking and risk factors and examination of a keratitis. So you have the filamentous fungi, the yeast and the dimorphic fungi, the parasites commonly encountered, acanthamoeba and microsporidium. So coming to the clinical features of bacterial keratitis, the thing to remember is that the patient usually presents with more symptoms, like patient will have severe lid edema, discharge, pain and defective vision associated with redness, photophobia and chemosis, signs of adherent mucopurulent discharge with underlying separation of the stroma, the adjacent cellular infiltration, you have iris signs, meiosis associated with posterior synechiae, and sometimes you might have a hypopion. Then the typical features of each type of bacteria. The typical keratitis, Staph aureus commonly presents with a oval yellow-white suppurative ulcer, may be associated with a dense stromal abscess, and the surrounding cornea is usually clear. You might have a large hypopion with an associated endothelial plaque. Streptococcus pneumoniae, typical in presenting with a serpiginous edge of activity, usually a dense, deep oval stromal ulcers with undermining edges, and might be associated again with a stromal abscess. Hypopion is a common feature with fibrin deposition on the endothelium. Pseudomonas, very notorious in creating rapidly progressive fulminating ulcer and usually associated with a yellowish green exudate on the surface, and the remaining cornea usually shows a ground glass appearance. Here in the picture you can see a rapidly progressive ulcer usually associated with a corneal melt and perforation, and the associated sclera is also inflamed, showing scleritis. Another type commonly encountered in extended wear contact lens users, you have a granular epithelial keratopathy. Coming to fungal, you have a patient presenting usually with more signs than symptoms. Usually you have a gradual onset of pain, foreign body sensation, photophobia with slight or watery discharge. The ulcer usually present as a dry, rough texture with a dirty white color. You can see the delicate feathery hyphae, and a very important point here is sometimes you might get to see a pigmentation of the ulcer bed. It might be mistaken for a perforated ulcer sometimes. The picture shown is a very small one, but sometimes you might have a larger pigmentation where you might mistake it for a perforation of the ulcer. Then usually you have a white ring in the cornea, the immune ring. Then an endothelial plaque is usually associated with it. Acanthamoeba, you have severe pain. The patient usually presents with severe pain out of proportion to the clinical signs. And as the disease progresses, you might encounter ring infiltrate. And with inflamed corneal nerves, you have the radial perineuritis, which is usually pathognomonic. Coming to risk factors, the history taking part. This is the most important part, that we have always have to elicit a detailed history of the patient. Always look for a history of trauma. Whenever you have a trauma with a vegetative matter, suspect a fungal or nocardial keratitis. Metal pieces such as these removed under unhygienic conditions. I don't know whether you can appreciate it. You have a person trying to remove a foreign body from the eye using their tongue. So in such cases, always suspect a pseudomonas keratitis. In contact lens users, you have pseudomonas or acanthamoeba being the primary suspect. And in post-LASIK, you usually encounter atypical mycobacteria. Always ask for a history of chronic topical use, chronic topical anesthetic abuse or a steroid abuse, application of native medications, and always ask the patient to bring the medication, to examine the medication by yourself in detail. Sometimes when you see, you might be seeing contaminated, extremely contaminated medications. Sometimes you might have foreign bodies, even insects inside the medication. So it is always important that you ask the patient to bring the medications and examine the medications by yourself. Examination of adnexal abnormalities such as a meibomian gland dysfunction or a trichiasis, nasolacrimal obstructions. Look for the tear film abnormalities, The conjunctiva, always evert the lids. Look for cobblestone papillae, any keratinization or scarring, membranes or foreign bodies. Look for the associated inflammation, ulceration and nodules on the sclera if present. Look for the cornea, look for foreign bodies, again thinning or perforation, signs of previous corneal or refractive surgery. Always examine the contralateral eye where you might get features of degenerations or dystrophy. So it is very important you see the contralateral eye. A foreign body such as this might be missed on a trivial examination. You might have a transparent tripod shaped foreign body. So it is very important that you examine in detail. Can I have the next slide? Yeah, look for associated systemic conditions such as these. Examine the ulcer with respect to the location, the shape of the ulcer, the characters of the infiltrate margin, the color of the ulcer, the endothelium and the anterior chamber inflammation. Always stay in when you are in doubt. Look for any epithelial defects, any loose sutures, look for the fundus, do a B scan to note the vitreous reaction, examine the contralateral eye as I have mentioned previously. The workup usually involves the corneal scraping, which will be dealt in detail in the next topic. Cotton swabs are usually avoided. Scrape from the margins and the base of the lesion, and whenever you have a contact lens user, do culture of the contact lens case, the solution. A confocal microscopy is especially useful in whenever you suspect a acanthamoeba, you have double walled cysts, and in cases where you have where your culture does not yield sufficient result, you might have to go for a corneal biopsy. So I would just like to sum up by concluding that a detailed history elicitation and a meticulous clinical evaluation will most often result in reaching an accurate clinical diagnosis so as to start a presumptive therapy even before you wait for the microbiological results to come. Thank you.
Yeah, thank you, Vivek, for that comprehensive coverage of the topic.